welcome. Today we are going to talk about new FDA approval for Wegovy, which is so exciting. But first, if you are new here, welcome. I'm Dr. Garcia Webb. I'm a board-certified physician in internal medicine, lifestyle medicine, and obesity medicine. And I'm also a certified life coach. I've helped hundreds of patients lose weight, and I'm here to help you too by answering evidence-based, by giving you evidence-based answers to your weight questions. So, and if you want to work with me directly, I'll leave that information here too. But today we're going to talk about the excellent questions that you have sent. And if you have questions after this, I'm going to upload it to my YouTube channel, Weight Medicine with Dr. Meghan. You can certainly leave more questions there after for the replay. So, all right, let's get into questions for today. All right, so first I want to talk about the new Wegovy approval by the FDA. This just happened this month. It's very exciting. So the FDA approved a new indication for Wegovy use, which is semaglutide, to reduce the risk of cardiovascular death, heart attack, and stroke in adults with cardiovascular disease and either obesity or overweight. So that is so exciting because it's another indication from the FDA means a broader category of people that the label for the drug applies to, and this means even broader coverage for patients in general with insurance. Now, technically, because if you have a weight-related, so if you have obesity already, with or without cardiovascular disease, this is going to, you're already in the category that that Wegovy would be approved for. But what is potentially very exciting about this is it increases the chance that insurance will cover, like Medicare will cover this, because up till now Medicare doesn't really cover anything for treatment of weight, which is ridiculous. But this is for treatment of prevention of cardiovascular disease for patients with these risk factors and weight. So hopefully this will be a new indication for things like Medicare that could help millions of people get covered who would really benefit and who don't have coverage now. So more news to follow. All right, so that's super exciting. And then that approval really came from the SELECT trial in 2003 in the New England Journal of Medicine, and I'll leave that link below too if you want to read more about that. Next question. All right, what about people who are not overweight or obese but are using Wegovy for binge eating or mindless eating or alcohol abuse? That's a great question. I think it really depends on, I think you're asking like can you prescribe for it? And that's a great question. And I'm just, as a caveat, I'm not answering personal medical questions, but just kind of broadening these out and to apply to everybody for medical education purposes. So yes, would I consider using Wegovy for somebody who was not overweight or obese but had a binge eating issue? Absolutely. The problem would be, because first of all, it can really help with people who have that food noise and those compulsions for binge eating. It can be really, really helpful. You probably wouldn't need to go up to the highest dose either. You can get an effect early on, but you also have to be careful with somebody's weight. So if I had somebody who had binge eating disorder and they had a BMI of 20, you just have to be careful. I would probably do a very low dose and see what the effect of. But the truth is, there are also other medications that are FDA approved for binge eating. So Vyvanse is a great option that can lower weight as well, but it also really helps. So it's definitely something I would consider. At this point, though, if somebody had a BMI that's below the cutoff for Wegovy, you just have to be totally upfront and be like, your insurance is like not going to cover this. So it's really more of like an out-of-pocket expense, and just patients have to be aware of that. But it's definitely something I would consider. Mindless eating, I think that's, my favorite way to address that is really with the coaching aspect first, because there's so many reasons why people are eating mindlessly. So probably not where I would go, right out of the gate, and again, out of pocket, and really have to be careful of somebody's BMI. But that's someplace where I would start with coaching first. Alcohol abuse, yeah, that could be very, and I've said this before, I think in the future we will definitely see more, as the medications become more affordable, I think we'll also see a lot more off-label use for these medications. And again, doesn't necessarily have to be at the highest dose. People might be able to get that kind of mind noise down with lower doses. So you wouldn't be as worried about somebody's weight with that. It's definitely something I would think about for alcohol abuse too. If patients had tried other things and hadn't been successful, yeah, can certainly help with the cravings. People just feel like they just don't want to drink anymore. They just don't even think about it, which is so liberating. But again, there are other medications that we have, like naltrexone, things like that, that are also good fits for people. So it's not that we don't have medications to treat these right now. It's just that this would be another tool that could be very helpful. So especially for someone who had maybe overeating and alcohol issues, and they really hadn't gotten very far with lifestyle changes, and you'd really kind of taken that as far as you could, definitely something I would think about for them. Okay, so when you are eating less, how do you cope with the hunger for the rest of your life? Oh my gosh, that's a great question. How do you cope with hunger when you're eating less? Well, I think the really important part is to, first of all, you really have to differentiate where the hunger's coming from, because there's your true physiological hunger signals come from your stomach. That's the only place that they are coming from. Like whether your body needs energy, that comes from your stomach. Now, we have a lot of other kind of triggers to, help us want to eat, that are, survival mechanisms from, built up over hundreds of thousands of years. So the true hunger comes from the stomach, but there's also a lot of inputs that come from, like, it's like mind hunger. It's like, ooh, that looks good. Ooh, that looks good. Like that kind of hunger, or I just want something to eat, that's mind hunger. And then there's stomach hunger. So step one is really tuning in. And this is boring. This is so boring. Like, this is why people don't want to do it, because it's boring and it's a little bit of work. But it really gives you a really good payoff. You want to just check in with yourself and see, okay, am I physically hungry? How does my stomach feel? Or am I physically satisfied, but my brain is just wanting this, or I want something that tastes good, or I'm a little bored, or there's all sorts of other reasons why we want to eat. So that is number one, is to see if you are truly hungry. And if you are truly hungry, you want to think about, this is somebody I would take a really good, go through what they're eating with a fine-tooth comb, because if you are eating a lot of ultra-processed foods, they're not going to fill you up as fast, and that's kind of how they're engineered, is to kind of provide your body with this hit of what it wants, like fat and sugar and salt. And then, you get hungry a lot faster, because they don't have your body has not evolved to really process these foods well. So it's kind of like a shortcut around all the things that our body is used to using for satiety. So if people are finding that they're very physiologically hungry, first of all, you want to make sure you're eating like the minimum, like none is best, but the minimum amount of processed or ultra processed foods or processed foods. That's step number one, because that can really alter your satiety signals. And also, I think if you are somebody who could take or leave diet soda or artificial sweeteners, I would really try to get rid of those, because I do find that they can increase cravings for some people. You know, some people are like, over my dead body, will you take my Diet Coke away from me? And that's totally fine too. But if you're someone who's like, yeah, I have this every once in a while, or it's not like a huge part of your life, you know, see if you can get away with that. Because it does, for some people, it can worsen those cravings. And the other thing to take a look at is really the what's in the food that you're eating. So does your food have enough fat? Does it have enough protein? And does it have enough fiber? Those are the really big triggers to tell our stomach, to tell our body, you know, are we full? So if you are not eating a lot of those, you want to kind of play around with, okay, what are the ratios, and how much of these components is going to keep me full? So it does take some experimentation, but I think it's definitely worth it to see, you know, what's going to trigger that true hunger feeling. And you want to get more in touch with that too. Like after every meal, you want to kind of play around with how full you are, how hungry you are. You want to really tune into those natural signals. Okay, so, okay. Can you titrate down the dose of Wegovy and stay at a low dose and then maybe come off of it? That's another great question. So I wouldn't. If somebody currently, I think in the future we'll have a much better sense at what we can do in terms of stopping the medication or kind of prolonging the time between doses. Like, what is a maintenance dose? What does that look like in the future? Like 5 years from now, I think that's going to look a bit different than how it does now. But we just don't have the research yet, and so a lot of this is anecdotal. I think it's so hard to get the medications. It's so hard to get them approved, and we know that they work when patients stay on them. So if I had somebody on them, I just want to keep them on that maintenance dose, and that's usually the highest dose. So Wegovy would be the 2.4 milligram dose. So I really want to keep them on that dose. I don't see a need to titrate them off of it, and it's not something that I'm going to push for if they're tolerating it well. I do have patients who, like, they want to give it a year and then try to titrate off of it, and we can do that. It's not my preference, but, you know, it's always really the patient's decision in terms of, do they want to stay on a medication or do they not want to? And as long as we've really gone over those risks and they really understand what that could mean, like the weight could come back off and then you have to go back up, and then I'm open to trying it, but it also is going to involve a lot of like really making sure that you're eating how you want to eat, exercising how you want to exercise. All that is really locked in. That is a great question. Why are some clinicians wanting to stop the medication after 6 to 12 months if data shows patients regain weight? Yeah, I don't know. I think it's just, I think there are a lot of people out there who prescribe who don't do it a lot, and so they don't have as much comfort with the medications or feel a little bit trepidatious about it, like especially things like phentermine, which is a controlled substance. You know, I definitely which is why I get a lot of referrals, is because a lot of, you know, a lot of people don't want to kind of deal with it, or they're not comfortable with it, or they don't do it a lot, and so they would rather just refer, which is totally fine. And I feel, you know, that's why, you know, obesity medicine physicians exist to help and to be the experts in that situation. But yeah, it's just not a good idea. I don't know why you would do that. I think a lot of people are just really worried about you know, what's going to happen after, or keeping somebody on a medication long term. And I think it's, I don't know. I don't know why they would want to do it. I'm guessing that they're just a little less familiar with the medication. And so, you know, if that's your clinician, I would definitely recommend finding an obesity medicine physician and having a talk with them too. They might want to take over that script. So, okay, that is going to do it for today. Thank you so much for watching. Please continue to send in your great questions, and please be well.